Estamos comenzando nuestro webinar hoy sábado 23 de septiembre con un tema controversial para algunos, un tema de mucha discusión en nuestra asociación. Hoy tenemos la suerte y la fortuna de tener como invitados al doctor Lars Blond de Dinamarca, quien fue la persona que describió la técnica artroscópica publicada en 2010. Nos va a contar su experiencia con el procedimiento y nos acompaña la doctora María Bassi, también colega nuestra de Medellín, miembro de ACCART, que nos va a hacer la revisión. Y también tenemos el placer de tener a Juan Pablo Martínez, nuestro coordinador del webinar. Así es de que sin más palabras, Juan Pablo, bienvenido for Lars. Thank you so much, Lars, for being with us.
Thank you.
And Juan Pablo, go ahead.
Muy bien, buenos días a todos. Vamos a iniciar entonces con el doctor Blond, que nos va a presentar su conferencia, donde va a hablar sobre la displasia troclear y sobre el desarrollo de esta técnica artroscópica para hacer la trocleoplastia. Dr. Blond, please, it's an honor for having you here, and you can begin now.
Okay, many thanks, and I'm grateful for the invitation. Sorry, I'm not able to speak Spanish, but I can present on this arthroscopic trocleoplasty, and hope you can see it now. I just wanna, where is that button to make? Normally the button is here to make it larger. Oh,
Right.
wait a second.
In your right.
Yeah, in the right, but the zoom is, yeah, there it is. Now I just had to move the zoom.
Yes.
Okay, so arthroscopic trocleoplasty. When should you do it and how should you do it? I will try to explain further. First of all, you have to realize there's a condition called trochlear dysplasia. Trochlear dysplasia is the flat groove, and it's the most common predisposing factor for patellar instability. Actually, severe trochlear dysplasia is seen in approximately 5% of the population in US, and that's quite a lot. Not all of those will have symptoms. Mild to moderate trochlear dysplasia is seen in 18%. So some will have patellar dislocation, some will have anterior knee pain, some will develop patellofemoral osteoarthritis, and some will never have any symptoms. What are the characteristics of trochlear dysplasia? First of all, a lateralized or a decreased lateral trochlear slope, meaning that there's less osseous support for the patella. And there's a decreased trochlear depth. There's a medialized trochlear groove. And then there's an elevated trochlear floor, also called the ventral prominence. If you look at X-rays and see the bone, you call it trochlear bump. But with cartilage, it's the ventral prominence. So one thing you have to know about trochlear dysplasia and about the knee groove is that the configuration changed from proximal to distal. Proximal, it tends to be flat, and this is where the trochlear dysplasia is localized. It's in the top of the knee. And if you look at the X-ray and MRI, this is an actual X-ray on the right and an MRI. It's the exactly same knee.
Problemático últimamente, doctor.
Look at actual X-ray.
La finca ya la consiguió, porque como usted y Felipe no están de acuerdo, entonces de conseguirlo.
Can be measured several ways. This is a method from Escala and his group. And if the groove is less than 3 millimeter deep, you will say it's trochlear dysplasia. Another thing is the trochlear facet asymmetry, and that means that the trochlear groove has moved medially, and that affects the TT-TT distance. Some look at the TT-TT distance and make their surgical indication based on that, but they have to realize that TT-TT is often just a medialized trochlear groove or an increased tibial external torsion. But that's another topic. So the definition of trochlear dysplasia, there are really no definition. This is still lacking, but there are some classifications, and all of them are subjective. The first was the one from France, from Bassi, and then there's all these different classifications, and the most used classification is the de Sure 4-group classification. The problem is that it's not reproducible. There are 11 studies out there saying it's not reproducible. You can use it as a binary classification. That means either you have low or you have high trochlear dysplasia, and then it works okay. And perhaps it's okay for indicating surgery if you distinguish between high and low. But for scientific purposes, you cannot use the de Sure classification. You have to use measurable parameters. And I think one of the most important parameters, that is the lateral trochlear inclination angle. And you're going to use the new 2-image technique, and I will show you that later in my presentation. And then there's the trochlear depth, I already mentioned, and the facet asymmetry. And then there's something called beaded anterior-posterior measurement. I will show you that later. But why trochleoplasty? Why not just do an MPFL reconstruction? I mean, it works quite well. But we actually don't know precisely when we should add a trochleoplasty. We know for sure that trochleoplasty compared to MPFL will provide with better stability. There is this review from Balcerek demonstrating this. And then there's this study from Sao. He looked at J sign and found that it was very much related to failure of MPFL reconstruction. So if you have a J sign, you have to realize that you probably not just can do an MPFL reconstruction because it won't last. And J sign, that is somehow related to trochlear dysplasia. There are other reasons for J signs. This is not part of this discussion. There are some failure studies out there looking at why does the MPFL failure. And in 50% of the cases, that was due to trochlear dysplasia. So they hadn't done a trochleoplasty, they just did the MPFL, and then it fails. So then there's the arthroscopic trochleoplasty. I mean, it is now 15 years down the line. I started out in 2008 with this technique. And beforehand, I did open trochleoplasties. The technique has been published in some journals, but there are 6 book chapters out there about the technique. You can find it on my webpage. They are here. But you can also see the surgical technique by going on Artrex, Bumedi, YouTube, or my own webpage. And then you can look at manuals, very nice video on Bumedi. I'm going to show you this video. And you see, you start out doing a standard lateral portal, and then you find the right spot for your suprapatellar portal, put in a switching stick. And over this switching stick, you put the scope, and now you see everything from proximal. And at the right, you see the lateral. part of the trochlear, you see that it's quite flat. I will put in a needle to find the right spot to put in a cannula, because most of the surgery is done through this cannula. I start out taking the synovial tissue away in order to be able to come in with my shaver burr later and to place my anchors when I have to reinsert the cartilage flake. Then I do the shaving with the burr. I will try to go into the cleavage between the bone and the cartilage. And normally that is quite easy, goes very smooth. But in order not to take away too much bone laterally, because I would like some osseous support, I avoid taking away bone laterally. And instead I use this osteotome, or lambotte, is it also called, chisel. And I also use it medially to release the cartilage. And then I continue with my shaver, make the groove deeper, and I go further and further distal, use the chisel again. And so I change all the time. Sometimes I also change my scope direction, so I use my scope through the lateral portal and my shaver through the suprapatellar portal. And then when I want to wake a lateral trochlear, I use this power rasp. I also use it to remove the bone on the rear side of the cartilage flake, because I wanted the cartilage flake to become elastic, so I can manipulate it into the new trochlear when I have made the right configuration. You see there is a little bleeding. I don't use tourniquet. I never use tourniquets for any of my surgeries since I'm a shoulder surgeon. And I just put up the pressure and keep my portals tight so it won't go too much water out. Then I'm going to place my first distal anchor. You can do that in the start of the surgery. You can do it in the end of the surgery. That's, yeah, doesn't matter. Put a push lock anchor. This is loaded with some vicryl tape in this video. This vicryl tape is resorbable, but you cannot buy it any longer. So you have to use multiple vicryl sutures, and they work just as good. Put in 10 sutures or five, so you have 10 double. That works perfect. So it's just because it's an old video. Then I will grab my tape or suture and bring it proximal through my portal and load it with a new anchor and make this this hole for my push lock anchor. I will reinsert the cartilage flake, make it tight, so it will push the cartilage flake into the new groove. Then I change my scope. So I will put the scope through my lateral portal. And then I will grab my suture from the suprapatellar portal, as you notice here. And then I will place my next anchor. Normally, in most cases, I place just 2 anchors proximal. In some cases, I place 3. You see, I still have 2 sutures left. So I can place a 3rd anchor proximal if I want to. However, in this case, I believe it was enough with 2 anchors. You will see that how it looks. See, it's the cartilage is stable and it looks okay. And then I will continue to do my MPFL reconstruction. Good. So what are my indications for arthroscopic trochleoplasty? Yeah, first of all, patellar instability. In some rare cases, I do it for chronic anterior knee pain. If they don't have increased femoral anteversion, and if there's no other good reason for their chronic anterior knee pain, I will provide them with a trochleoplasty. But in most cases, it's patellar instability. And for my clinical examination, I use the positive reverse dynamic patellar apprehension sign. This is a long word, but it's described by Zimmerman, and I think it's a very nice test for the patient and also for the examiner. You start out in flexion, and then you start to lateralize the patella and look at the patient. And when they start to become apprehensive, you measure the number of degrees. It has to be positive above 30 degrees, because then it tells me there are some bony problem and you need to fix that. You cannot just do an MPFL reconstruction. And then I look at the lateral trochlear inclination angle. If it's below 9 degrees with the new two-level image technique, it indicates trochleoplasty, and the same with a positive J sign. So these patients, postoperatively, they are allowed full weight bearing, free range of movement, no brace for many years. I haven't used braces, and it's one-day surgery. We recently did a study just to check out if the MRI looks okay after an arthroscopic trochleoplasty, because some surgeons said you cannot do it arthroscopically. I wanted to prove you can do it arthroscopically. And then we measured on the four most proximal levels. What we measured was the lateral trochlear inclination angle, the trochlear depth, asymmetry, anterior posterior width, what's the beta thing, and then the patellar tilt. And this is the two image technique. If you look at the left picture here, you will find the posterior condylar line, femoral condylar line, where the condyles are most prominent. And then you will place a post-it on your screen, and you will scroll proximally, like here, until you see the most proximal picture where you see cartilage in the trochlea. And then you put a line tangent to that, and you measure the difference between that and the line up here. And what we found in this study was that preoperatively they have minus 0.4, and they went to 10.3, and at level 3, 2.9 to 13.9. So that was significantly better, nearly normal, but not normal. The trochlear depth went from 0.3 to 2.9, and so on, and it also nearly normalized. And the same with the facet asymmetry, significant better. And with this anterior posterior divided with the width, we found that at level 1, we went from 81 to 74, and from level 3, 80 to 76, and normal, it's 73. So it becomes nearly normal. For the cartilage thickness, because we wondered, will the cartilage be thinner some years after? And this was a 5-year follow-up. No, it was actually the same. It was somehow a little bit higher, but not significant. So it looks good. For the patellar tilt, patellar tilt, for me, patellar tilt is that the lateral facet of the patella articulate with the lateral facet of the trochlea, and when the trochlea is flat, the patella tilt, and if you deepen the groove and make a trochleoplasty, the patella will come down into the new trochlea, and the patella tilt will be normal. And that was what we observed in our study. So why do it arthroscopically and why don't do it open? What does the literature say? There are no comparable studies yet, unfortunately. This was my last open one. It gives absolutely better spacious orientation. However, the open technique is naturally, it gives more pain, and there is a higher risk of scar formation and arthrofibrosis. And I just heard from one who worked with David Desure in France that 1/3 of his trochleoplasty needed secondary removal of scar tissue and brisement manipulation. So in the pro for doing the arthroscopic trochleoplasty, I think it's minimal invasive surgery, less pain, smaller scars, less risk of arthrofibrosis, less risk of infection, less risk of cartilage flap breakage. And this is just an example of pre and post-operatively. You notice the lateral trochlear inclination angle is nearly normal, and then you see the patellar tilt is reduced. So the clinical results after this 5-year follow-up with 16 knees, you see the BAM score, which is a new good score. I hope it's translated to Spanish because it's much more precise than previous scores. It went from 37 to 74. So that is okay results. So today I've done more than 200 arthroscopic deepening trochleoplasties. And in the last 100, I haven't had any complication. And I think that's quite incredible because I naturally, just like any other surgeons, I have complications, but not in this procedure. But previously I had one redislocated, that was case number 7. She had increased femoral anteversion, and one with severe pain that was also increased femoral anteversion that I overlooked. And then I had 3 DVTs. So when people are above 30 years, I will now use antithrombotic medicine. I have had no infection, no arthrofibrosis. So this is the spread out now. These countries do arthroscopic trochleoplasties. And this is just a case. I don't know if, have we time for this?
Okay. Yes, you have.
I think this girl here, she had more than 100 patellar dislocation, and she had a medialization of the tibia tubercle when she was in the age of 16. She had the screws removed and had synovectomy. She had MPFL reinsertion. She had a new arthroscopy, and then I met her in 2012. And I did this arthroscopic deepening trochleoplasty and MPFL reconstruction. Before the surgery, she had these extremely low scores. She couldn't barely walk from the bed when she had to walk from the bed to the toilet. So she was really bad. You can see this is her walking, and this is how her X-ray looked before, and you see the convex groove, and you see if you use the X-ray, you see the ventral prominence trochlear bump. Let's see if it works. And this is her 14 weeks post-op. I think it's quite incredible thinking about how she was before the surgery. And that is naturally since she had a very good physiotherapist who really helped her through. And this is her results after the surgery from 7% to 77%. So that was quite amazing. And this is pre and post-op MRI of her. And this is just, I'm not sure it's her, I can't remember, but this is just one of those. You see the difference. And this guy, he came from Hawaii. and went to Copenhagen to have this arthroscopic trochleoplasty and MPFL reconstruction. And he didn't want to come to the 1-year follow-up, so he sent me this video instead. Okay, that was it. Thank you.
Thank you, Dr. Blond. That was great. Really nice technique and complete review of all about trochlear dysplasia.
Good.
We're gonna have some questions at the end, and now we're gonna go with Dr. Bassi.
Yes.
Ana María.
Listo, yo pues creo que me escuchan, voy a compartir la pantalla. Todo bien, ¿cierto?
Sí, estamos viendo todo muy bien.
Bueno, entonces la idea en estos siguientes minutos es hablar de inestabilidad patelofemoral y qué nos dice la evidencia. Revisamos este tema, vemos que, la mayoría de los pacientes que tienen una inestabilidad
Creo que perdimos a Ana
Algo le pasó a
María.
Ana. Espérate,
Problemas de conexión.
algo le pasó.
Mientras regresa Dr. Blond, Ana María had some problems, so I'm going to ask you something. When you have...
Ana ya volvió.
no sé qué pasó.
Okay, so let's wait for the questions.
Yeah, we wait.
Bueno, entonces, como les decía, a pesar de que la displasia troclear es altamente frecuente en los pacientes con inestabilidad patolofemoral recurrente, no es uno de
Ana
los
María, pon la imagen en proyección, porque ponlo en proyección. Y estás en la número 1.
En modo presentación, doctora.
Modo presentación.
Pero no sé cómo lo hago. Modo presentación.
En la parte de abajo de tu pantalla dice comentarios, notas, hacia
A la
tu
derecha.
lado izquierdo.
A la derecha.
No.
Al lado de un libro, al lado de una
Sí, pero es
pantalla.
que yo no estoy viendo eso, estoy viendo otra cosa. Ya me perdí. Que me voy a dejar de compartir y lo vuelvo a hacer.
Te toca de pronto minimizar la vista de todos los conferencistas para que te deje ver ese botón
Sí, ya.
cuando ya estés compartiendo.
Ahí está bien.
Sí, no, no está en modo de presentación.
Porque yo sé que no me tiene que hacer, me habla.
Tú tienes abajo,
O
ahora
arriba,
sí.
arriba también dice presentación con diapositivas. Es otra.
Tengan paciencia,
Ya.
Ay, qué tristeza.
Listo.
Ya. Ya se
Dale.
ve.
Entonces, es que me va a sacar.
La saca. ¿Por qué te saca, Ana María?
No sé, apenas pongo que voy a compartir mi pantalla, me saca el Zoom.
Entonces hazlo
¿Será
hazlo sin compartir. Déjalo sin hazlo ahí, a ver.
Bueno,
Vale. Pasa a la siguiente.
listo. Ya me cambio. Listo, ya. Entonces es una cirugía que igual poco realizamos y está dentro de los procedimientos, como hemos hablado muchas veces, acerca del manejo de la inestabilidad patelofemoral con cirugías a la carta según las necesidades del paciente. Sin embargo, lo otro que vemos en la literatura es que se ha descrito la trocleoplastia como una cirugía que es difícil, que técnicamente necesita un cirujano muy capacitado para hacerla y que es un procedimiento demandante. Está indicada y tiene unas indicaciones precisas, sobre todo en pacientes con displasias de alto grado, o sea, pacientes con displasias de B, C y D, que tienen una inestabilidad patelofemoral, finalmente que no tienen una artrosis avanzada y que uno ya haya abordado previamente o no tengan ninguna alteración rotacional o en otro punto de la alineación. Se ha usado tanto para intervenciones primarias en el primer momento de tomar la decisión de llevar a cirugía a un paciente con inestabilidad patelofemoral o en aquellos pacientes que ya han tenido alguna intervención y que tienen como complicación un nuevo episodio de luxación porque probablemente no se había abordado la displasia troclear. Entonces, ¿qué nos dice la evidencia? Lo primero es que la mayoría de resultados en cuanto a trocleoplastia son positivos, pero salen generalmente de series de casos y de seguimientos que son a corto y mediano plazo. Y en trabajos que tienen una particularidad y es que hay mucha variabilidad en los procedimientos. Generalmente todos los pacientes, además de la trocleoplastia, se les hace algún otro gesto en relación con la inestabilidad patelofemoral y además que los pacientes suelen ser heterogéneos en cuanto a sus características clínicas. Eso hace que tomar la decisión de hacer una trocleoplastia sea algo compleja y que nosotros básicamente nos basemos en la opinión de expertos y de sus series de casos y en unos principios que desde el punto de vista anatómico nos parecen como lógicos. Inicialmente encontramos entonces estudios biomecánicos o de anatomía, en donde varios autores han mostrado que tener displasia troclear va a aumentar las presiones de contacto en la articulación patelofemoral y además va a disminuir la estabilidad de la patela. Hay otros trabajos que han visto cómo en cadáveres hacer trocleoplastias va a hacer que la profundidad del surco aumente y que haya una disminución de la distancia TTG, eso provocando que se mejore la estabilidad de la patela. Y en cuanto a los desenlaces clínicos, lo que hemos visto es que desde los primeros episodios procedimientos de trocleoplastia que se hacen desde hace como un siglo, la evolución de las técnicas ha hecho que los resultados sean cada vez mejor. Vamos a hablar pues de las técnicas que se hacen actualmente, que son la del grupo de Jur, que es como una técnica de unos flaps que sean gruesos, la técnica de los flaps más delgados, que básicamente tiene su modificación artroscópica por el doctor Lars, y la técnica de Butelier, que simplemente es una cuña de resección para disminuir como el bump que tiene el paciente, más que hacer una profundización del surco. Entonces, traje más o menos como un resumen para que hagamos un recorrido, espero no muy aburrido y rápido, sobre los resultados de la trocleoplastia. Como pueden ver en la columna del lado izquierdo, la mayoría son series de casos, nivel 4, incluyen algunas, pues, variada cantidad de pacientes y de rodillas. Realmente se hizo para pacientes que tuvieran displasia severa. En estos primeros trabajos vemos que la técnica que se usó fue la técnica de Jur, con seguimientos de 6 y 13 años, y lo que se vio es que había unos pacientes con una alta satisfacción, que tenían una mejoría significativa en escalas funcionales como el Pujala y el IKDC. No había, no era poco frecuente que el paciente tuviera reluxaciones. De hecho en este segundo estudio del 2003 habían 0 nuevas luxaciones, pero algunos de los pacientes, hasta el 20%, pueden persistir clínicamente con aprensión o con signo de la J. Otra serie de casos del 2013, 21 pacientes, 24 rodillas, también displasia severa por antecedente de tener cirugía fallida. Se hizo trocleoplastia con la técnica de Lyon, también la mayoría de veces asociado a otros procedimientos, 0 luxaciones, los pacientes tenían disminución del dolor, mejoraba el Pujala, pero algunos clínicamente seguían teniendo aprensión. Luego, cuando empezamos a evaluar el estudio de la parte inferior, la técnica ya de la trocleoplastia el flap más delgado, con 2 años de seguimiento, también muy buena satisfacción y mejoría en muchas escalas funcionales, ojalá y KDC, el Lisham o incluso el WOMAC. Misma técnica, otra serie de casos, 2 años de seguimiento, ninguna luxación, mejoría en el dolor, satisfacción hasta el 95% en los pacientes, mejoría de escalas funcionales y de escala visual análoga del dolor. El estudio de la parte inferior también, pacientes con displasia severa o displasia de alto grado, solo una nueva luxación en estos 50 rodillas, pero los pacientes, algunos seguían con aprensión, con signo de la J y mejoría igual de las escalas funcionales como describí. Esta es una serie un poquito más grande, casi 200 rodillas, la misma técnica, hasta 12 años de seguimiento, aunque en promedio estos pacientes fueron seguidos alrededor de los 4 años, con una satisfacción alta, mejoría de los síntomas hasta el 90%, incluso mencionan retorno a actividades deportivas del 73%, mejoría significativa en escalas funcionales y recurrencia a un nuevo episodio de luxación, en este caso de un 8.3%. y en el seguimiento una artrosis o hallazgos de artrosis que se vieron hasta el 7.7%. En este caso, con la artrosis, los autores hacen una observación, es que algunos de estos pacientes se llevan a cirugía ya con algunos cambios iniciales en el cartílago. Entonces, como el objetivo principal es resolver la inestabilidad, probablemente sea muy difícil definir hasta qué punto hacer la trocleoplastia ocasionó o empeoró que desarrollaran una artrosis. Esos trabajos creo que ya los mencionó el doctor Lars sobre modificación de esta misma técnica del flap delgado, pero eso asistido, pues, todo hecho por artroscopia, también complicaciones poco frecuentes, no nuevas luxaciones, mejoría en todas las escalas funcionales y en el COS en todos los aspectos también hubo mejoría. Y el estudio que él mencionó también de evaluar los cambios en resonancia, además de mejoría en escalas funcionales del COS y del Pujala, se veía que los pacientes después de la trocleoplastia artroscópica tenían una efectiva pues, disminución del bump, aumento en la profundidad del surco y en las relaciones patelofemorales. Si nosotros hasta el momento vemos que la mayoría pues son, o todos son series de casos, que es un nivel de evidencia bajo, entonces básicamente nos basaríamos en la experiencia de esos expertos. Y si nosotros buscamos últimamente qué resultados hay en cuanto a revisiones sistemáticas, otro tipo de estudios en cuanto a trocleoplastia, solo hay 12 resultados cuando buscamos en PubMed. Esta primera es una revisión sistemática que evaluó 15 artículos, trocleoplastia en inestabilidad, básicamente nuevas luxaciones solo el 2% de los pacientes, mejoría en escalas funcionales, persistía en los pacientes clínicamente la aprensión. Este otro trabajo de Longo en el 2017, una revisión sistemática de 14 artículos, al final 392 rodillas, evaluó además de cómo iba la trocleoplastia, buscó separarlo por las diferentes técnicas abiertas que existen y se encontró que había una mejoría significativa en cuanto a la inestabilidad y el soporte funcional de los pacientes. Este otro trabajo habla sobre el uso de trocleoplastia como una técnica aislada o acompañada con otros tratamientos en inestabilidad patelofemoral. También recogió 12 estudios, 700 pacientes. A 504 se les hizo solo una trocleoplastia y a 198 trocleoplastia más otro procedimiento, en la mayoría de los casos reconstrucción del ligamento patelofemoral medial. Lo que se vio es que había una mejoría de las escalas funcionales, tanto si la cirugía se hacía aislada, pues con un Pujala de 80 a 92, mientras versus la cirugía también con otros procedimientos con una mejoría hasta el 95% y con tasas de nueva luxación del 0 hasta el 8%, solo con hacer incluso la trocleoplastia. En cuanto a complicaciones, esta es otra revisión publicada en el 2021, 28 estudios, 5 de ellos incluían las primeras técnicas que les estoy diciendo que son hace un siglo, donde solo se hacía elevación de la parte lateral de la tróclea, con técnica de Jur, y ya los 12 y un solo estudio de las otras técnicas, 890 pacientes, pues alrededor de 1000 trocleoplastias con seguimientos que van de 1 a los 25 años. Y lo que se vio en resumen es que la luxación después de hacer trocleoplastia con cualquiera de esas técnicas es del 2.4%, artrosis lo tendrían hasta el 27% de los pacientes, y rigidez o alteraciones en la movilidad que puedan requerir alguna liberación o otro procedimiento, un 7%. Y ahí vuelve y juega lo de la artrosis, porque se vio que las técnicas iniciales, las que se usaban antes de estas nuevas técnicas, que son las que ahora hacemos o conocemos, sí podían tener mayor relación con los cambios de presión en la trófea y el desarrollo de artrosis en los pacientes. Les traje más detallados esta revisión sistemática del 2017 del doctor Longo, porque ahí podemos ver más o menos como una comparación que se hizo entre las técnicas que hay, 371 pacientes, 392 rodillas, se hizo en pacientes con inestabilidad recidivante que tuvieran displasia de alto grado y siempre se asoció a algún otro procedimiento según la necesidad, como hemos hablado siempre de cirugía a la carta. Estos son los estudios según el tipo de trocleoplastia que se usó, las escalas funcionales y el número de procedimientos que se realizaron. Como vemos, la que más se realiza es la técnica que tiene el flap delgado. La mayoría de los procedimientos en esta revisión, o sea, el 63% fueron con esta técnica. Y en cuanto a la mejoría en las escalas funcionales, fue mayor o al menos más reportada en las técnicas tanto desde Jur, del flap más grueso o la técnica del flap delgado. Si nosotros evaluamos complicaciones, dicen que hay 40% de complicaciones. Las más importantes son aumento del dolor, la artrosis y que el paciente presente una nueva luxación. Sin embargo, en esta cantidad de pacientes, aumento de dolor solo del 11%, 43 pacientes. Era en estos porcentajes, generalmente en los que se hace la resección en cuñas, eran pacientes que eran pues, quedaban sin dolor o era poco probable que hubiera dolor postquirúrgico. Sin embargo, cuando nosotros evaluamos el trabajo que describe esto, esta trocleoplastia de resección en cuña se propuso inicialmente para pacientes que se les hacía cirugía de estabilidad patelo-femoral, quedaban estables pero persistían con dolor. Entonces simplemente se quitaba el bump y los pacientes les mejoraba el dolor. O sea, fue una cirugía que se diseñó inicialmente para mejorar el dolor que quedaba luego de haber corregido por lo menos la parte de la estabilidad. En cuanto a la artrosis, también vemos que suele ser mayor cuando se hace la técnica de Yuro, eso es lo que se puede ver por los estudios en esta revisión. Y la nueva luxación es poco frecuente, son complicaciones solo el 2% de los pacientes, y ahí están más o menos los porcentajes. Si nosotros vemos y comparando entonces las técnicas, probablemente la que tenga menos complicaciones y sea efectiva es la técnica del thin flap, que tiene pues, dolor 10% de los pacientes, una nueva luxación incluso el 0.8% de los pacientes y solo 4.4% de hallazgos de artrosis, siendo incluso la más utilizada en los estudios que les mencioné. Entonces, en resumen, ¿qué nos dice la evidencia? Lo primero es que la displasia troclear es un factor clave en el manejo de inestabilidad que se debe evaluar y se debe clasificar, que la trocleoplastia mejora los desenlaces clínicos y funcionales en los pacientes con displasia severa e inestabilidad patelofemoral, entonces es una cirugía que es efectiva. Sin embargo, es difícil evaluarla como un procedimiento único porque la mayoría de los pacientes van a tener otras alteraciones, entonces van a tener otros procedimientos que se van a asociar a la técnica. Todas las técnicas sirven, al menos en controlar la estabilidad y en mejorar la parte funcional de las escalas de los pacientes, y ninguna ha mostrado que sea superior. La trocleoplastia que más se usa es la trocleoplastia del thin flap, es un procedimiento que suele ser más eficaz en términos de reluxación, de artrosis y de movilidad. Sin embargo, la puntuación en escalas funcionales, por ejemplo, de Pujala, es mayor con la técnica de ello. Muchas gracias. En este correo pueden ver las referencias.
Muchas gracias, doctora. Una revisión muy completa, muy interesante y vemos que esta es una técnica demandante y que puede tener complicaciones y que seguramente también tiene una curva importante en su proceso. Vamos a pasar entonces a discutir y algunas preguntas. Quisiera empezar. I would like to begin asking Dr. Blond about his recent study. Dr. De Jour has said that mostly what we do when we do a trochleoplasty is take the bump off, and that maybe we are not deepening so much the trochlea, but from the measurements you did, I found that you could really change also the shape of the trochlea, right? I think you are in silence. You have to open your mic. Yeah.
Yeah. Sorry. Yeah. The thing is that we have also done some. If you read the last paper about trochlea shape, we have also measured how far distal do we actually go with this arthroscopic technique, and we come rather distal, and thereby we reshape the groove so it looks quite like a normal trochlea. And I don't think the same way that David De Jour think. I think what David De Jour say is never do a trochleoplasty in a De Jour type C. And I mean, when you're not able to see the difference between B, C, and D, how can you say like that? I do it in those with severe trochlear dysplasia, and I normalize the look of the groove all the way down. And even if there are no trochlear bump or ventral prominence, I still do the trochleoplasty in order to provide the knee with a good osseous lateral support and to unload the patella. That is the thinking about how I do it. And after I listened to Anna Maria's very nice talk, even though I couldn't understand, I could see the papers, what it was about. And I wanted to comment about osteoarthritis, because now I have been doing trochleoplasties for nearly 20 years. And I do a lot of patellofemoral prosthesis. Most of them, 80%, is due to trochlear dysplasia. But I haven't had any of my patients coming back to me, and those I have been giving a trochleoplasty, saying, now I have osteoarthritis in the knee and I need to have a prosthesis. So I think I'm not sure about the importance of osteoarthritis. Maybe they get radiographic osteoarthritis, but they don't have any pain.
Very interesting. And going back to the shape of the group, some authors have said that the shape of the patella is somehow also like dysplastic, and that it's congruent with the dysplastic groove. So they think that maybe only take the bump would be good because of the pressures between both bones. What do you think about that?
I mean, it could be in some cases. I haven't had any of those cases yet where you see this really convex lateral facet of the patella. But what normally happens is that if you make a good lateral facet of your new trochlear, the lateral facet of your patella will fit to that. And it will never articulate on the medial side, only on the lateral side. So even though there is a strange looking patella, it hasn't been a problem yet. But it could be, it might be in some cases that you need to do an osteotomy of the patella, but I haven't seen one yet.
Juan Pablo.
Sí. Adelante.
I'm gonna say this in Spanish and then in English, Lars. Esa pregunta siempre es un motivo de discusión de las colegas que no creen en la trocleoplastia. En términos generales, esta enfermedad no se manifiesta con una displasia de la rótula, excepto que la faceta medial es más corta en la mayoría de los pacientes. Yo también he tenido casos muy raros en el cual la patela es completamente displásica. Enfermedad que tradicionalmente la rótula tiene las dos facetas. Lars, my thought about the patella is rare to find a flat patella in this disease. Just you can see the medial facet is shorter than the normal, but you have the two facets. So, and just in one of my case, I had a flat patella, but I did the trochlea, and the patient is stable until now. What happened 2 years ago? But normally the patella is normal, you know? What do you think?
I haven't had any patient where the shape of the patella was a problem.
Yeah.
That's just it. And the patella shape, the normal patella shape, at least in those with dysplasia, it's often like it's in the bottom it's V-shaped, in the top it's flat. You know, the purple bee, the big bee that cannot fly. If you take an engineer, they say it cannot fly, but it flies. And it's the same with this. The patella might look wrong, so you think I should not do a trochleoplasty, but you do a trochleoplasty and the patient becomes happy. I mean, that's another thing that I haven't mentioned is that when you can do the trochleoplasty by arthroscopic technique, your indications change. because what you see is that it's just a small surgery. The patient go home the same day. They have really no pain from the trocleoplasty. The pain comes from the MPFL reconstruction. So therefore, you tend to do more trocleoplasties. So my indication, not like the international well-recognized indication. I tend to do more.
Agree. Ana María, te quería preguntar, el doctor Blond habló sobre incluso hacer trocleoplastia en dolor anterior de rodilla. ¿Encontraste algo en la literatura? Creo que no hay mucho sobre ese tema.
Sí, pues digamos que como el tema era inestabilidad, yo me enfoqué en eso. De lo que encontré que me llamó la atención, uno fue la técnica de brutalidad de hacer la cuña, que se hace es en pacientes que ya se les hizo una cirugía de estabilidad cualquiera, la rótula se estabilizó, pero el paciente tiene dolor. Entonces, inicialmente la técnica se describió haciendo la resección del bone, no para quitar la inestabilidad, porque el paciente ya se le había quitado, sino para que el paciente le mejorara el dolor y le mejoró el dolor. Incluso encontré un reporte de 2 casos del doctor, donde se hizo para dolor patelofemoral de más de 1 año de fisioterapia sin mejoría, que ya se hizo todas las cosas posibles, se hizo una trocleoplastia y se me aliviaron.
Interesante, y esperaremos más evidencia
Es
en ese
tiempo.
tema. Dr. Blond, two controversial topics, and also from the questions that the people are doing. One, it's about open physis. So you are aware, I believe, about Nelly's study that that they publish about those open physis kids that are after their growth peak, they can do trocleoplasty. So do you have any experience with that? And then about patellofemoral arthritis. So when you don't have a good cartilage in the groove, I believe it's impossible to do a thin flap technique. So, but sometimes I think that maybe you could do a thick flap for those patients. So a little bit about your thoughts about these two topics.
First of all, with the open physis thing, it's often the girl who has this problem, and if they have had menstruation for 1 year, I do an arthroscopic trocleoplasty. I have done it in several cases where the patient was 12, and I didn't see any closure of the physis, any growth problem. That's one thing. For the people with the grade 3 and 4 cartilage lesions in the trochlear area, I have done several arthroscopic trochleoplasties, and I have just made a thin flap, just like the other. You can do it, and maybe there will be a short, you can say, hole in the flake, but you are able to reshape it and put it down. And they haven't had any pain. They haven't had any problems with flap breakage. Some of them are operated more than 10 years ago. They still haven't returned. They were very painful before the surgery, but not after. And then I want to mention one thing, one crazy thing, and that was due to Simon Donald from UK. I met him because I had some patient who, for some reason, did not want to have a patellofemoral prosthesis because it was metal, but they want to have surgery. And I said, the only thing I can try is I can try to deepen your groove. I take away the cartilage, I just make a groove in the bone, and it will be like a huge microfracture. And actually, their pain improved enormously. They did not become perfect, but they could live with the pain. One of them returned 4 years after and had a patellofemoral prosthesis, but just the thing, deepening the trochlea, tend to take away the pain.
So it would be like something like in the shoulder, like rim and go, something like that?
Yeah, you just, I have made a paper together with Simon Donald, and an editorial, and he had some cases and I had some cases, and we published that. So sorry, it's just I have a guest coming now, but we just continue. Yeah.
Juan Pablo, una pregunta para Lars.
Excuse me?
Lars, yeah. Can you hear me?
Yeah, I can hear you.
Okay, Lars. There are about 4 or 5 papers that they shows that even in severe dysplasia, just doing the patellofemoral reconstruction, the patient's going well, you know? You know that paper.
Yeah, I know.
Unfortunately, you know that paper. Okay. Unfortunately, in never of that papers, the authors describe what kind of severe dysplasia they are talking about. Okay?
Yeah.
So what do you think? Because this is the more strength arm that they know do patellofemoral reconstruction. And when you see the results, many of them are good results, but almost all the studies include just the Kuhala.
Yeah.
In my thought, Kuhala is not good for evaluation, this patient, because even patient that has instability again, they got a good Kuhala score. So probably the BAMF is better. What do you think about?
I mean, I see those patients because they come back to me with pain and rupture of the MPFL. So most of those papers are from US. They're so scared about the Trocleoplastia, and I wish they will do it with the BAMF score, because then they will find out that these patients are not doing good. I mean, you can put in a big nail into the knee, and if you put a nail, the patella will get stable. You can put in a very thick graft, a semitendinosus or double-centered tendinosus, and the patella will not dislocate, but the patient will not be happy. And I think that Trocleoplastia is giving better results. If you do a randomized controlled trial, I'm sure Trocleoplastia plus MPFL reconstruction would come out better than just MPFL reconstruction. That's my point. But if you look into the literature, you cannot say that it's not good enough just to do MPFL.
We are now finishing. We translated both BAMF and Norwich to Spanish, and we have finished recruitment already, and we are hopefully we'll have that publication soon.
Fantastic.
That will be useful. Yeah, maybe we are almost finishing here, but we would like to know about torsional problems of the femur and trochleoplastia and trochlear dysplasia. So do you see them together much? Because sometimes you can get messed with femoral anteversion and confuse it with trochlear dysplasia. And so what are your tips for this?
I mean, if there are severe torsional problems together with trochlear dysplasia, I will do a combined surgery. So I do the arthroscopic trochleoplasty first, and then I will do the femoral derotational osteotomy and eventually tibial rotational osteotomy as well.
Okay, and sometimes when you only see the MRI axial image, you confuse that anteversion with trochlear dysplasia. But when I think that using the lateral inclination angle trochlear inclination angle, it would be very useful because you're taking the posterior condyles, and it would be helping a lot to understand what's happening with the shape, right?
I agree, yeah.
Yeah, and also when you have a perfect lateral X-ray, you're gonna see if there's a supratrochlear spur or not, and that also might help. Yeah.
I never use X-rays for that. I don't
No.
trust X-rays. If it's a good X-ray, I will look at it, but normally it's not part of my my investigation. I don't ask for an X-ray. If there is an X-ray, I will use it, but if there isn't any, I will just use the MRI, and then eventually I will do long-standing X-rays or make a rotational profile with either CT or MRI.
Question.
Mosco alguna, sí.
Sí, Lars, have you experienced doing isolated trochleoplasty? Just the trochleoplasty and reaching the medial, not doing a medial patellofemoral reconstruction?
Yes, I do that.
Or you always do the, okay. In which cases you prefer to do just reaching and not patellofemoral reconstruction?
No, if there is instability, I will always do an MPFL reconstruction. If it's
okay.
just for chronic
My question is, my question is, in patellofemoral instability, have you do isolated trochleoplasty, or you always add the medial patellofemoral reconstruction?
Always, because the trochlea does not provide any stability for the patella between 0 and 15 degrees. So they will tend to become unstable if you don't do the MPFL.
But because probably you are in my age, when I was starting my orthopedic practice, we do medial reefing.
Yes.
For a long time. And goes very well. Yeah. And there are 3 or 4 papers that shows same results doing isolated trochleoplasty plus reefing compared trochleoplasty with medial patellofemoral reconstruction. So what do you think?
I mean, I've done a lot of medial reefing, and I thought they were doing good, but I tend to see them years after, and they didn't go. They were operated elsewhere, or so. We thought they were doing good because they lasted for 3-4 years, and then they redislocated. And I mean, why do a reefing when you can do an MPFL reconstruction that works?
Okay. You use the tubercle osteotomy in cases when the TTTG is over what measurement? Which measurement?
I mean, normally I don't use
19, 20, 15.
I do one medialization a year.
You don't like you.
I don't like medialization. I lateralize the trochlea.
Like it, like me.
Or I do a derotational tibia osteotomy. I don't do medialization of the tibial tubercle. It's really rare. I mean, for the past year, I've done one. So I think the TTTG is a very difficult measurement, and it can guide you a little bit. And I know that the medialization of tibial tubercle is somehow the working horse for many surgeons, but I don't like it. I like the distalization, but not the medialization.
Okay, good.
Good?
Good, very good.
Well, thank you to Dr. Blond, Dr. Bassi, and all of our members that were connected today. This was a great morning for us, afternoon for you in Europe.
In Denmark.
In Denmark,
yes.
Yeah.
In Denmark, yes. So many thanks to everyone and to Anna Marie, everyone else. Have a nice
Thank you so much,
much.
Lars. Thank you
Gracias.
for your time to show your technique. We appreciate your time. Lo mismo, Ana María, gracias. Juan Pablo, muchas gracias a todos los que nos acompañaron en este webinar. Espero lo hayan disfrutado. You have to come to Colombia, Lars.
You just invite me, please. Yeah, I will come.
Yes,
And thank you, Manuel,
I'm sure.
for inviting me.
So see you in ESCA, Lars.
See you, yeah.
Juan, gracias a todos.
Gracias.
A Patricia, a Laura, a Camilo, a todos. Ana María, muy bien, muchas gracias. Estuvo muy bueno, gracias, Juan Pablo.
Gracias, amor.
No,